care nutrition and organ transplantation, diabetes and renal nutrition, and cancer nutrition, geriatric nutrition, pediatric nutrition care, enteral nutrition, and parenteral nutrition. And coming to the presentations and the publications, she has organized 12 national and international conferences in clinical nutrition, and 5 publications in international journals and 10 publications in national publications. We welcome you, ma'am, and you can start the session.
Organ transplantation, especially the solid organ transplantation. The solid organ transplantation includes heart, lung, kidney, and liver and pancreas. So this topic is like of late, probably you can say last 4 or 5 years, the number of organ transplantation is increasing, majorly due to the awareness. Every year, India is doing around 25 to 30 organ transplantation, 25 to 30,000 organ transplantation, and in the recent years, the number is gradually increasing, but still we are unable to near the requirement of organ transplantation, because nearly 1 to 1.5 lakhs people require organ transplantation every year. So we are achieving only 25% of it. So transplantation is nothing. It's the transfer of human cells, tissues, or organs from a donor to a recipient with the aim of restoring the function of the particular organ or a tissue or a cells. So there are so many type of transplantation happening, and today we are going to see the organ transplantation. Can be a living donor transplantation or a deceased cadaver transplantation. And see, this is actually the entire topic discussed today. So in that, so many like whether it is a COPD, liver disease, all of them, the final stage, they may require transplantation. And by the time they come for transplantation, they all malnourished only. Most of them, nearly 80% of the people who come for transplantation are already malnourished. So that is mainly because of the decreased dietary intake, because of their symptoms related to diseases like anorexia, changes in the taste and nausea, vomiting, and then early satiety in the presence of ascites or organomegaly, impaired digestion and absorption. All this can cause malnutrition in the pre-transplant stage itself. So what happens? The outcome of the transplantation is affected due to the pre-transplant malnutrition. So what increased operative blood loss and the transfusion is required, long ICU stay, infection rate also increasing, higher mortality, post-transplant nutritional lag also can happen. So due to the inflammation, recovery from the infection and increased work for breathing, all these increases the demand for more nutrient. So what happens, in this stage, the macronutrient disturbance, like low, there is a demand for more carbohydrate calories. There is a demand for high protein, because catabolism is increasing. There is a lot of glucogenesis happening, and the increased amino acid ratio. So all this happens, disturbs the macronutrient metabolism. Lipid increased, fat oxidation because of lipolysis happens, malabsorption of fat soluble vitamin happens, so deficiency also happens, and associated pancreatic insufficiency. These are the micronutrient disturbances happening in this stage, and there are vitamin and mineral and trace element disturbances also happening, mainly fat soluble vitamin A, D, E, K, and Sometimes water soluble vitamin also happens because of malabsorption, and zinc, iron, calcium, magnesium, copper and selenium deficiency is also very common in the pre-operative stage itself. And after the surgery, in the post-operative stage, especially in the first 2 weeks, there is, the patient goes into catabolic state because pre-operative malnutrition, graft function, stress of surgery, both physiological and psychological stress, immunosuppressant drugs, and organ dysfunction, and sometimes infections like sepsis can cause this catabolic state. So what should be the nutritional glow? Correct malnutrition, prevent metabolic complications, most important, improve the quality of life. Any treatment, the ultimate aim is to improve the quality of life and reduce perioperative complication and proper nutrition education during the admission and also discharge. Because I always believe that the patient and the relatives should be informed about what type of nutrition therapy a patient is getting, even if they are getting oral nutrition supplement or enteral nutrition supplement, total parental nutrition support. You have to explain to the patient, if possible, or to the relatives. So the nutrition therapy process starts with screening, assessment, diagnosis of nutrition deficiencies. Care plan should be developed, and you should implement your care plan, monitor, evaluate, and educate during the discharge. This is the nutrition care plan for transplantation, and these are the some of the guidelines about post transplant nutrition care. We all know that not much of Indian guidelines available for transplantation. Even international guideline also very less guidelines is there. Old guidelines are there, but latest guidelines are very minimum. So what they say is regular assessment of nutritional status and qualified dietary counseling shall be required while monitoring patient on the waiting list before transplantation. Yeah, I think people who are working in a transplant center know that when the doctor decide that this particular patient should be taken for transplantation, and during they register, there'll be a pre-operative evaluation going on. In that, nutrition also is a must. This is by the government. So the patient should undergo a nutritional assessment and proper care and counseling. So that helps the patient to get a better nutrition during the waiting time for transplantation. And recommendation for living donor and recipient are no different from those for patient undergoing major abdominal surgery. And malnutrition is a major factor influencing outcome after transplantation. So monitoring of the nutritional status is recommended. In malnutrition, additional ONS or even enteral nutrition is advised. So what we do in our organ transplantation unit is, if the patient is malnourished during the follow-up OPD visit before the transplantation, if the patient is unable to eat and unable to meet their requirement to a level of 50%, we immediately tell the patient that it is time to get a good nutrition care, and we admit those patients and start some nutrition support, preferably enteral nutrition support for some time until they eat oral diet and meet the recommended dietary allowances. And after the heart, lung, liver, pancreas, and kidney transplantation, early intake of normal food or enteral nutrition is recommended within 24 hours. Even the ERAT guidelines also says that if the patient after surgery and after a normal extubation, that is the ventilation time is normal, like after transplantation, you keep the patient on for 6-7 hours of ventilation and they recovered, and you are planning for extubation. If oral diet is possible, we have to encourage that. And unfortunately, more 80% of these patients continue with the ventilation for more than 24 hours, and we have to start on enteral nutrition. So it is important to start early enteral nutrition. In our center, even in the post-surgical observation time, we start the enteral nutrition for the post-transplant patient. Even after transplantation of small intestine, enteral nutrition can be initiated early. There is no need to wait for days. You just can start within 24 to 48 hours. And for simple reason, nasogastric, easy way of feeding can be continued. And polymeric feeds, semi-elemental feeds, if intolerance necessary, EN and PN should be combined together. Long-term nutritional monitoring and qualified dietary counseling are recommended for all the patients, and oral feeding after enteral are tolerated. So this is how the guidelines says about the nutrition care. So coming to the screening, I am not going in detail because in previous presentation also they have explained about it. So the most common screening tool used in India and worldwide is NRS and MUST. So there are more MNA and so many other tools also is there. You can use any of these tools. Then complete nutritional assessment pre-operatively and post-operatively. See, what happens is you should not continue with the pre-operative nutritional assessment. So after the surgery, there may be some changes happening. So you have to assess for those things also. So it is important in the post-operative ICU. We should reassess the patient. So you all know ABCD is the best method for nutritional assessment. That is called a complete assessment, and hand grip method is the latest technique which everyone has started using, and there are a lot of studies saying that it is a good assessment tool to find out the hand muscle strength. And whatever tools are there, whatever materials are there, including those CT scans and MRI scan and ultrasound reports, that also measures the body composition, right? It's more beneficial if you have the body composition for nutritional assessment. So whatever source is available, make use of it. And to assess the malnutrition, subjective global assessment is the commonly used, and it is simple, easy, and most validated. So I prefer subjective global assessment, even though we have tried Nutric score in some of the transplant unit, like lung transplant unit, but we were unable to complete it on time, and a lot of information we have to wait for it. So it is better to go with the subjective global assessment itself. And this is the combined recommendation for all transplantation, calorie and protein and other nutrient recommendation. And if you see, most of them are recommending a protein of 1.3 to 2 grams. And this is all, again, I said, no, there is no latest guidelines for transplantation available. This is all 2015 and 14 guidelines combined. And they all say that during the recovery, immediate post-operative and time of 3 to 6 months, they should be given a high protein. Then for a long-term goal, they should be given a normal regular protein of 1 to 1.2 grams. So this is a 2014 guideline. That is why you can see 0.8 grams. Now 0.8 grams is not at all a normal protein. So it's all 1 gram to 1.2 grams. That is called normal protein recommendations. And caloric, almost all organ transplantation people required 30 to 35 kilocalorie for short term, probably 3 months to 6 months, and depending on the recovery of the patients. And for maintenance, 25 to 30 calories. You should use body weight, and in case of obese patient, adjusted body weight can be used to calculate the calorie requirement. But one mistake even I observe in my students also, when they prescribe, they tend to give when an obese patient is there, they tend to give calorie for adjusted body weight and also protein. So that we should be little careful. And fat, even liver and pancreatic transplantation, not necessarily you have to reduce the fat. Probably you can always see whether it is a calorie, protein, or whatever it is. We start with slow rate and slowly increase it, gradually increase and achieve the target in 3 to 7 days. That is what we aim. So in that, when you are giving initially 50% or 60% of the total recommended calorie, protein, and other nutrients. So obviously you are giving less fat only. So no need to worry about whether to give a low protein, a low fat, or no fat, because there are some doctors, they insist on no fat feeding in liver and pancreatic transplantation. So no guideline says that there shouldn't be any fat restriction in the liver and pancreatic transplantation. Another thing, micronutrients, we all should check in when a patient is having a oral nutrition supplement with the oral diet. Well and good, they'll be almost getting all the micronutrients. And even in enteral nutrition, whatever the products are available in the market, they all have sufficient amount of micronutrients. But when it comes to parenteral nutrition, if your patient is on parenteral nutrition, we have to supplement micronutrients, both multivitamins and trace elements in particular. So we should be initiate that. So these are some of the other guidelines. This is the SPEN. This is the latest 2020 guidelines for liver transplantation. Same thing. They also suggest that pre-operative assessment and nutrition care is very essential, and 30 to 35 kilocalories and 1.2 to 1.5 grams of proteins, and branch chain amino acid enriched formula, not necessarily. We always use the regular TPN and regular polymeric formula only. We really don't go with the specialized like hepatic nutrition formula after the transplantation. Before transplantation, maybe we just assess and go with such product, but after transplantation we always go with the regular products. And this is again the lung transplant recommendation. So same only, whatever we have seen, the same recommendation. And this is for renal transplantation and recommendation. So here you see the protein recommendation to start with 1.2 to 2 grams. Then slowly it can be brought down to normal 1 gram per kg body weight. So again, in this is also a little bit old recommendation, and you can see 0.8 grams. So the 2022 guidelines, all critical care guidelines, they all say that 1 gram is there, 1 to 1.2 gram is the normal protein requirement. And see, this is very important in pediatric. Yes, ma'am. I'm completing it.
Thank you.
Okay, so pediatric, you can continue with a regular recommendation, whatever you are following it, whether ICMR or WHO, whatever guidelines. And along with that, you have to use the stress factor to calculate the calorie and protein. So the drug and nutrient interaction is very, very important. Almost all the immunosuppressant drugs given to the patient should be counseled about it, and what are the expected side effect, and you have to explain to the patient and what are the nutrients should be restricted in that particular side effect. Like for example, that all this medication increases the appetite, and people tend to eat a lot of carbohydrate and fat, end up in increased triglyceride and blood sugar level. And most of the kidney transplantation patient and a few of the heart transplant patient gain weight after 6 or 7 months of post transplant period. So that should be given. So because post transplant too much of weight gain is not advisable for the implanted organ. So that should be explained. Most important, food safety after organ transplantation, because these patients are suppressant patient. They are taking immunosuppressant, so they are immune compromised. So all measures to be taken care. We have to educate during the discharge, not only the nutrient requirement, also about how to follow the food hygiene practices. We have to in fact we explain them about how to purchase, clean and separate, how to storage, what temperature they have to store. All this should be explained to the patient. To summarize my presentation, assessment of nutritional status is the first step, and if you do that rightly on time, then the rest of the steps are very, very easy to follow. And whatever tools are available, make use of it. Body composition, well and good. And pre-operative nutritional therapy is important for post-transplant recovery. And pre-operative oral nutritional supplement and enteral nutritional supplement is beneficial. Follow all Aspen and Canadian guidelines and ERAS guidelines. Immunosuppressant drugs and nutrient interaction to be educated to the patient. Food safety and hygiene to prevent foodborne illness to be all followed during the admission time, hospitalized time, and educate them during discharge to follow at home. And regular follow-up of the patient is very, very important. Thank you so much for the patient listening.